We can start, ma'am. We are on.
Just you can take the countdown.
We are on, ma'am. We are live.
Good evening and welcome everyone to the DOS Postgraduate Education Program, DOS PEP as we all know it. And as you all know, currently we are in the oculoplasty series in the lecture 20. So, with the guidance of Professor Rohit Saxena sir, our President DOS, Dr. Prafulla Maharana sir, Secretary of DOS, and our treasured Professor Kirti Singh ma'am, who has been constantly supporting us with in conducting these virtual classes that is benefiting a lot of students, not just from Delhi, but all across our country. So today we are here to talk about a very important lecture that is retinal tumors. And we have with us an eminent speaker, Dr. Deepshekhar Das. Our course coordinators are Dr. Pallavi Singh. She has done a post-graduation and senior residency from RP Center and pursued a fellowship in oculoplasty and ocular aesthetics from University of California in Los Angeles. Currently, she is in private practice. She is also an assistant editor of IGO. Our other course coordinator is Dr. Puneet Jain, who is consultant in charge of the oculoplasty department in Sharpsight Eye Center in New Delhi. He's done his post-graduation from RP Center and done a long-term fellowship under Dr. Santosh Nawar, sir, under Dr. Santosh Nawar. He has also pursued a fellowship under Dr. Paul T. Finger in the Department of Ocular Oncology and Ophthalmic Radiations. Our panelist today, who's going to be discussing this topic, is Dr. Ankita Aishwarya. She's done a fellowship in oculoplasty and ocular oncology under Dr. Santosh Nawar, and currently she is working in PGICH Noida. She is a reviewer of the American Journal of Ophthalmology and various other reputed PubMed Index journals. And she has various awards to her name, including the AI's International Hero Award, the Best Paper Award at the American Academy of Ophthalmology, and the Bangladesh Ophthalmic Association and Oculoplasty Society of South Asia have also awarded her for her scientific work. Our speaker for the day is Dr. Deepshekhar Das, who has done her post-graduation and senior residency from the prestigious Dr. R.P. Center for Ophthalmic Sciences and currently is working as an assistant professor at AIMS New Delhi. He has over 70 publications and has authored multiple chapters in the field of oculoplasty. He's a member of the team which described the double globe in a single orbit sign, the boomerang sign, and the disinsert retract rotate technique of brachytherapy plug. He's a reviewer in the AJO case reports, BMJ case report, and various other scientific journal. He's the assistant editor in IGO and IGO case reports. And so with this, I would like to hand over the dais to Dr. Deepshekhar Das. He is handling the ocular oncology and orbit and oculoplasty and neuro-ophthalmology department at the AIMS New Delhi. And he'll be guiding us on the topic of retinal tumors today.
Thank you, Pranita ma'am, for the kind words. Let me share my screen. So, just wait. Is my screen visible?
Is visible and you're audible and you're good to start.
At the outset, I would like to thank Delhi Ophthalmological Society for giving me this opportunity. Special thanks to Professor Rohit Saxena sir, Dr. Praful Maharana sir, and Kirti Singh ma'am. So today I'll be talking about intraretinal tumors. So whenever we are talking about intraretinal tumors, it's actually a vast chapter, a vast topic to discuss on. But today I'll primarily focus on the one which is the most common, which we encounter relatively often. So let's dive in. In 2018, WHO published a book where they have classified eye tumors per se into three distinct categories, mainly the intraocular ones. So intraocular tumors, they are divided into three groups. One which is limited to the uveal tissue, that is iris, ciliary body, and the choroid. Then the tumors of retina, which is the primary topic of discussion today, and the optic tumors of optic disc and optic nerve. This is the overview of the chapters which they also have in that book, and I will always ask all the postgraduate students to, if possible, they should go and read this book, the 12th edition of WHO, which was published in 2018. So let's dive into the most common retinal tumor which we usually encounter, that is retinoblastoma. So it's a primary malignant neoplasm of the retina that arises from the immature retinal cells. and it's also the most common primary intraocular malignancy in childhood in all racial groups. It's also the second most common primary intraocular malignancy in all age groups, and the most common one is obviously the uveal melanoma. Coming to the presentation of retinoblastoma, as per a study which was conducted at our center, RP Center, roughly a decade back, the most common presentation is leukocoria, followed by proptosis, red eye, squint, and then reduction is vision. But in the present day scenario, usually after leukocoria, which is still the most common presentation, we usually encounter squint, and phthisis is the third most common. But then again, the studies have to be published. Coming to the classification of retinal blastoma, it has been classified by multiple groups. The one which we usually use at our center is the International Classification of Retinal Blastoma, where it has been the disease, the intraocular disease has been grouped into 5 groups, from group A to group E. Group A being lesions which are small in the sense that is less than 3 millimeter in size. Here in the, I think you can see my cursor. Uh, the image on the top right, you can see that these are lesions, white lesions, which are quite appreciable. The size is almost compared to the disc, so it's less than 3 millimeters in size, and they are away from the disc as well as the fovea, that is 1.5 millimeters and 3 millimeters, respectively, from the disc and the fovea. So these are called Group A lesions. Group B lesions are ones where which are more than 3 millimeter in size, and they can be were located on the macula as well as in the nearby the optic nerve as well. And some groups believe that subretinal fluid, which is less than 3 millimeters away from the margin of the lesion, can still be considered as group B. And group C is the one where focal seeds appear. Focal seeds in the sense that it can be either seeds which are located just underneath the retinal layer, that is subretinal seeds, or it can be located just on top of the retina within the vitreous cavity, as vitreous seeds. Focal seeds is something which we call it focal because it's located within 3 millimeters from the retinoblastoma lesion, and it has the classification has also classified the lesion in the group into C1 to 3, one being a subretinal, two being vitreous seeds, and three being when both these are noted. Coming to group D's are diffuse seeds where there is subretinal seeds of more than 3 millimeters. And D1 and then D2, there is vitreous seeds of more than 3 millimeters, and D3 is when both subretinal seeds and vitreous seeds are noted. The most common presentation in group Ds are patients with large lesion with almost a total retinal detachment. So whenever a retinal detachment patient comes to you with with an obvious mass which you can see, you must be suspecting, or the likelihood of that being group D or E is high. Now, the next one is the group E, also known as advanced retinoblastoma. It is defined as any lesion if it's more than occupying more than 50% of the globe, or it has neovascular glaucoma, or opaque media because from hemorrhage in the antechamber vitreous cavity of subretinal space. And other than that, I always keep it simple. It's very easy to remember it. If the lesion has spread beyond the retina, it's group B. What does it mean? It's basically if it's limited to the retina and it has spread beyond it, in the posterior aspect, if it has reached the optic nerve, in the side, if it has reached the choroid or the sclera, until it has reached the zonules or the lens or the anterior segment, it's all group B. Coming to genetics and histopathology, RB1 gene is the tumor suppressor gene, which is responsible for the for this disease. So let's move on to histopathology. Talking about histopathology of these kind of tumors, what happens is that they are made up of small basophilic cells. Small in the sense the cells are small, however, they have a large nuclei and basophilic, hyperchromatic, and the cytoplasm are is extremely scanty. So these is one of the formats which we can be seen that is undifferentiated, or they might be found where they are arranged in rosette structures. They can be found in also known as flexor intestinal rosettes, or they can be found as fluid forms. Coming to the how exactly it happens, basically, as we all know, all cells, be it cancer cells or normal cells, all they undergo the process of cell cycle. And the RB gene actually is associated at this level, that is from the G1 phase to the S phase. So here the RB gene has an important pivotal role. It acts as checkpoint. It doesn't allow from G1 phase to the S1 phase to occur. So what happens is that if there is a problem or any mutation at the RB gene, this will eventually give this cycle will be disrupted and eventually will give rise to retinoblastoma. Coming to the two-hit hypothesis by Knudsen, which is extremely popular these days. It's basically he was a geneticist who first noted that who documented that in patients of retinoblastoma, both the alleles of retinoblastoma gene have been inactivated. So in familial, there is already an in the next slide I'll show you. There is already an inherited inactivation of one of the allele, whereas in sporadic, both of the alleles get inactivated spontaneously. So here, so in familial forms, what happens? All somatic cells inherit one mutation from the carrier parent, and the second mutation inactivates the RB locus in one or more retinal cells, which gives rise to the retinoblastoma. Whereas in sporadic forms, both these alleles are independently inactivated in the same retinal cells. So what's the importance of significance of knowing this is that we can kind of have a rough idea about the we can predict how it's going to affect the siblings or the offsprings of the individual patient. So a patient with retinal blastoma with a positive family history, the likelihood of that person's siblings having the disease again is 40%, whereas for offspring it's 40% again. But a person with no family history developing retinoblastoma, we have to see whether it's unilateral or bilateral. If it's unilateral, the likelihood of that person, a sibling to develop retinoblastoma is 1%, and it's roughly 8% for the offspring to develop retinoblastoma. Whereas in case the person has a bilateral retinoblastoma, the likelihood of the person's siblings to develop it is around 6%, and 40% of the offsprings to develop retinoblastoma. So what next? A patient presents to your center, and then you notice that there is leukocoria. What's the next step? The most obvious thing is that we should get an ultrasound done. And what do we find in ultrasounds? We usually see that there is a mass within the vitreous cavity with mild to moderate amplitude spikes, with in fact specks of high amplitude spikes as well, which indicates of calcification. And so here it's a typical image which is seen. This is a left eye image, as you can see here. B by A scan. The B scan is showing a large lesion occupying the vitreous cavity, and as we are passing the A vector through it, and there is corresponding kind of high amplitude spikes. So they may also be associated with retinal detachment. So after this, after getting an ultrasound, what should we do? We should always get a imaging done. The purpose of imaging in patients of retinoblastoma serves mainly three things. Firstly, it helps in the diagnosis. Then it helps in determining the extent, and then we plan the follow-up as well. How? Let's discuss about it. So when we're talking about the diagnosis, there are certain differential diagnosis that usually comes into our mind where patients may present with a leukocoria. For example, a patient of PHP, that is persistent hyperplastic primary vitreous, a patient with Coats disease, or even a patient with a post-traumatic retinal detachment, old retinal detachment might present to us with a leukocoria, and we might be in a dicey situation where to decide whether this patient is actually having retinoblastoma or something else. So that is, in such scenarios, MRI plays a pivotal role as well. Then when evaluation is limited to the due to media opacity, for example, a person is having some form of cataract or any form of hyphema, and we are not able to picturize or visualize the posterior segment in such scenarios also. Yeah, obviously an ultrasound will also help, and additional to the ultrasound, an MRI also gives you a brief, it helps you a lot. Then another important point is that in such scenarios, in retinoblastoma, the likelihood of tumor seeding, in case if you perform a biopsy, it's high. So it's always contraindicated. So always get an imaging done instead of getting a biopsy done. Next, moving on to the extent, yeah, the disease also helps not just in grouping, it also helps in staging that whether the disease is limited to the intraocular cavity, that it's limited to the inside the eyeball, or it has spread up to the optic nerve as well. Or it can even help you determine intracranial extent, and many a times it can help us pick out um, pinealoblastoma with bilateral retinoblastoma, which is also known as trilateral retinoblastoma. Even in cases of follow-up, imaging also helps, because in many cases, post chemotherapy, we have to notice, or we have to determine how much the disease has progressed or regressed. Um, and Imaging also helps in determining that. So what kind of imaging is ideal? There is contrast enhanced fat suppressed MRI of brain and orbit. The three sections, that is coronal, axial, and sagittal views. 2 cuts passing through optic nerve and pineal gland. The important part is that fat suppressed image has to be done, because the orbit is started, orbit, inside the orbit around the optic nerve, there is a lot of fat. And in case there is a fat which is, in case we don't suppress the fat, it may actually cause some problem for us to understand whether the optic nerve is involved or not. So this is a contrast enhanced. This is not a enhanced MRI. This is a simple diffusion, simple T1 weighted imaging. Here you can see that there is something in the right eye as well as in the left eye, but left eye we cannot see. So this is a T1 weighted imaging. On the T2 weighted imaging, here we can see that the vitreous cavity becomes white, water becomes white in T2s, and the lesion, it's very evident in the T2 imaging. However, it's also evident in the left side, but then again, it can be still in the left side, it can still be something else, like retinal detachment can be there. So once we get an enhanced imaging of this gadolinium, enhancement of these lesions are done, they enhance beautifully, and you can see that there is a large lesion occupying the both sides of the both eyes basically, and we can conclude that this is a bilateral retinoblastoma, possibly bilateral retinoblastoma. Okay. So after that, what is next step? Next step is that we have to get an examination and an anesthesia, and retinoblastoma patients have to be properly examined under anesthesia. And the purpose of getting an examination and an anesthesia is that we have to document not just the anterior segment findings, but also the most importantly, the posterior segment findings. Fortunately, at our center, we are having red cam, where we get a wide angle view of the posterior segment. And in also all currently all those centers which are dealing with retinoblastoma, they are equipped with the red cam. But in case it's not there, a person can use indirect ophthalmoscope with videography recording. They can use handheld red cams as well. Handheld fundus photographs, which are currently used these days as well. So these are of primary importance for documentation, because and one has to properly screen the 360 degree of the ora serrata. Everything we have to be screening it properly. We should not be missing out on a single lesion, because if we miss out on a single lesion also, that can come back and may even become fatal for the patient. So this is a typical group A lesion, like I described previously. It's far away from the vital structures of vision, as in the optic nerve or the fovea. So this is a group A lesion. This is a group B. This is a group C. Why you call it group C? Because here you can see that these spots which are seen, these are possibly in the vitreous cavity, and it is associated with subretinal fluid as well. Underneath, you can see that subretinal seeds are there here, and these are in the vitreous cavity. So there is a vitreous seeds, but then again they are lying in close proximity to the lesion. So it's a group C. So these are group D lesions. Group D lesions, there are multiple forms of vitreous seeds I will be discussing in the latest slides. So this is a group D, where you can see that there are multiple lesions, subretinal lesions throughout, as well as some lesions. There is also retinal detachment in this aspect. Talking about group E, like we discussed, that if the disease has spread beyond the retina, that is the optic nerve, the choroid, the zonules, lens, or even the anterior segment, is a beautiful photograph where anterior segment is studied with seeds, and seeds have deposited even in the iris. Coming to UBM, UBM plays an important role when patients where we are having a small lesion very anteriorly, where close to the aura, but we're not sure if it is actually going beyond it, if it's touching the choroid or not. In such scenarios, ultrasound by microscopy plays a pivotal role. So typically, infiltration of iris, we should be getting an UBM done. But then again, once we see that iris is involved, it's obviously a group E lesion. So these are typical UBM findings here. A patient is seen with anti-segment seed, and with the same patient, we can see that there's a ciliary body. There are multiple. Um, there's a lesion here as well. The retinoblastoma has spread up to the ciliary body. Other imaging modalities, CT, though it has been described that it is quite sensitive, but then again, it has a lot of advantages. Advantages include it's less, it doesn't take much time, and it's quite cheap, as in the sense it's less expensive. But disadvantages are more. That is, there is always a patients with retinoblastoma might require radiotherapy, and in the longer run might require multiple radiation doses. So again, exposing the same person with radiation doesn't make sense. So risk of CT associated radiation induced fatal cancers is always there. So it's a disadvantage. And other than that, infiltration of choroid and sclera cannot be carefully or clearly assessed by CT scans. So, and other than that, also optic nerve invasion can be commented, but then again, it's better commented or can be easily seen in case of better seen in cases of MRIs. So after the imaging, what is to be done? One should do a thorough systemic evaluation, that is a complete hemogram, liver function test, kidney function test, in order to rule out any systemic spread. For suspicion of metastasis, one should get a CSF cytology, bone marrow aspiration, bone scan. Then we should always get a lymph node palpation. We should palpate all the preauricular, retroauricular, as well as the neck lymph nodes, just to ensure that we have not missed out on any lymph node mets. And then, okay, these are conditions where the disease has already spread. Let's not divulge there. The role of PET scan is extremely limited, but currently it's not advised these days. But then again, maybe in the future, the idea is the reason is the same. That is, it's again CT scan. It can also cause radiation-induced problems. Coming to the treatment of retinoblastoma, we have three-pronged approach. That is, the most important step is to save life. Then, after saving life, we have ensured that we have managed to save life. Then we should think about saving the eye, and then last would be to salvage vision if possible. So how do we go about? We first of all perform focal therapy. Focal therapy is performed mostly for smaller lesions. And focal therapy includes the following, that is transpupillary thermotherapy, laser photocoagulation, cryotherapy, and periocular chemotherapy. I'll discuss one by one, each one of them. So coming to transpupillary thermotherapy, indication is a small tumor that is less than 4 millimeter size, posteriorly located. Posterior in the sense it should be, at the level of equator or further posterior to it. The problems with it is that in case the TTT is misfired at the iris, it can lead to focal iris atrophy. If it is misfired at the level of lens, it can lead to lenticular opacities. And even in case of normal individuals also, a high powered thermotherapy, higher heat will also give rise to retinal scarring. And in cases a patient already having some form of retinal traction, it can further induce retinal detachment. So they are also not suitable for seeds, that is subretinal or vitreous seeds. Thermotherapy doesn't play much role. So in case of typically small discrete lesions which are located maybe slightly on the posterior aspect, TTT is the treatment of choice. Coming to laser photocoagulation, it was previously used. Currently, we are not using mostly. The ones which was previously used was argon laser, 532 nanometers. They act the way basically they destroy the blood supply and then induce apoptosis. And the indication for usage is the same. That is, it has to be small in size. Small in the sense it has to be less than 4 millimeters in size, and the thickness has to be less than 2 millimeters. Coming to transscleral cryotherapy, indication is again it has to be small, but then again it has to be anterior. Unlike the ones which we do transperineal thermotherapy, we usually do transscleral cryotherapy for tumors which are located anteriorly. And there is also a limit to the height. Anything which is more than 3 millimeters will not be properly cryoed based on the cryo machine as well. So it's preferred that the lesion is less than 4 millimeter in diameter and less than 3 millimeter in thickness. And it has to be a discrete lesion. And the order which we follow is that triple freeze slow thaw cycles. And the disruption is the way it usually acts is the same. That is, it causes disruption of the cell membrane and causes the tumor to just die off. So what happens is that I will show you some photographs. So here you can see that there was a lesion here in the, it's quite anteriorly, and while after doing cryo, the lesion has disappeared. But one thing that you can notice is that there's a lot of scarring. So it's expected in cases of retinoblastoma. Once we do cryo, there is expected to be a lot of scarring around the um, lesion. Once it disappears also, there will be a permanent scarring. Yeah. Coming to plaque brachytherapy, it's as retinoblastoma is quite radiosensitive, and it has potential of absorbing ionizing radiation, which eventually leads to DNA damage and loss of reproductive capacity, and that eventually induces cell death. So, s- okay. So currently there are modes of two radioactive elements which are used for doing radiotherapy, so plaque brachytherapy. Uh, One which we use at our center is ruthenium 106. Currently, we're not employing iodine 125, but let's talk about the benefits and we can compare them. So iodine 125, the type of radiation is gamma rays, whereas in case of ruthenium, it's beta rays. Half-life is more in case of ruthenium, that is 374 years, 374 days. I usually remember it like more than just 1 year, 10 days for ruthenium, and 2 months for iodine. Other than that, the depth of penetration is less in ruthenium, that is up to 6 millimeter, whereas for iodine, it's up to 10 millimeters. Advantages, the advantages for iodine is kind of the disadvantage for ruthenium. That is, it treats thicker tumors, whereas ruthenium, there is sharp fall and lesser dosage delivered to the adjoining structure is also kind of, to certain extent, the advantage for the ruthenium as well. But then again, it in cases if the plaque moves a bit also from its original location, then the likelihood of the tumor recurrence is extremely high. There's also higher radiation to normal tissues for iodine, which is extremely less for ruthenium. So indication is that group B lesions more than 3 millimeters, which are not amenable to cryo or laser. We usually prefer doing brachytherapy. Uh, yeah. So and even with tumor with localized seed, we can do. But the thing is that the localized seeds has to be within 3 millimeters of nearby the tumor, so that it can be uh, within the apex of the brachytherapy. So these are the certain disadvantages and certain advantages and disadvantages. That is, it causes direct treatment of the tumor with minimal scarring, deeper penetration, minimal periorbital tissue damage, lesser risk of secondary malignancies, short duration of treatment, less risk of ipsilateral, orbital, and facial hypoplasia as compared to external beam radiotherapy, which we'll also discuss in the subsequent slides. Coming to disadvantages, not effective in large or multifocal recurrent tumors, which I was talking about. That is, in case there are multiple lesions, we cannot do brachytherapy by a single plaque. But then again, there are ways where rotated brachytherapy plaques has been tried. Side effects include cataract, radiation retinopathy, papillopathy, vitreous hemorrhage, squint recurrence of the lesion in case the lesion has not been properly covered by the radiation. Um, and it also requires precise tumor localization and measurement from its largest basal diameter. So one thing that one has to remember is that whenever we are planning for a plaque brachytherapy, uh, the measurements have to be done very close to the actual date of procedure. For example, if we are planning for a brachytherapy uh, today, then we should get an ultrasound and calculate the height along with it, and all the imaging should be corroborated, because in case we plan for you know uh, the brachytherapy after a week or so, and there is slight change in the size also, that can also affect overall significance of the brachytherapy. Okay, and periodic follow-ups are also required. It's a must. So these are the two plaques which we usually use. One is a notch plaque. It's typically designed for even for lesions which are located quite near to the optic nerve. The dimensions are 21 millimeter and 1 mm thickness, and this is a 15.8 millimeter plaque, rounded. So the the procedure is that first of all we have to measure the basal diameter and then the apical height, and the dosimetry is calculated by medical physicists. We have a separate team, and the idea is to deliver the dose of 40 to 45 gray at the apex. Moving on to chemotherapy, there are two forms of chemotherapy, that is systemic and local. Systemic means intravenous chemotherapy, and local means intraarterial, periocular, intravitreal. So, systemic chemotherapy is used because retinoblastoma is highly chemosensitive, and we usually advise chemotherapy in two scenarios. Mostly, if the patient is bilateral retinoblastoma, um, or even for cases of unilateral group B lesions, it has been documented, but we usually prefer giving bilateral, initiating it for bilateral or even for extraocular retinoblastomas. For in such scenarios, the cycles are different. For unilateral group B lesions, I think 6 cycles are enough. In case of bilateral, also 6 cycles are enough. For extraocular retinoblastoma, the total cycles has to be 12. Moving on to the regimen which we follow is VEC, that is vincristine, etoposide, and carboplatin, which is practiced worldwide. Um, and baseline investigations of complete hemogram, LFT-KFT has to be done on a routine basis. Bone marrow aspiration and biopsy, it's usually not done on a regular basis, but in case of METs or suspicion of MET, it has to be done. And in few centers, they are also practicing this on a regular basis. That is getting a CSF cytology done before even starting a chemotherapy. So these are the doses. Uh, they can be given in a standard dose or a high dose. Uh, all the three medications are usually given, and the number of depending upon the number of cycles, the doses are fixed actually. So moving on to the local type of local chemotherapies, that is first is periocular chemotherapy. It is typically used in group D and group E lesions to achieve high local concentration of drug. The injected drugs are carboplatin and topotecan mostly. The advantage is that they help to achieve high and rapid levels of drug within the vitreous cavity. The disadvantage is that it causes periocular edema, ecchymosis, and obviously the fat gets atrophied. And many a times it causes a problem in the muscles which are nearby and eventually leads to strabismus. Then comes intravitreal chemotherapy. It's usually done for patients who are having diffuse or focal seeds, because otherwise seeds are not tackled with any form of cryo or even for transpupillary thermotherapy. They usually don't get the vitreous seeds. So the drugs which are used, okay, let's discuss about the types of vitreous seeds. It has been classified into three types. First is a dust type, then is a sphere, and then it's a cloud. One thing that one should remember is that dust, they usually appear as granules and look they are located uh, typically all over throughout the vitreous cavity, uh, and In case of spheres, they are located more or less near to the macula and the equator, whereas the clouds, they are kind of punctate vitreous opacities. They are located more towards the aura, and they are found diffused. Talking about the after the chemo is given, the patient might have regression of the tumor. That is, and there's a classification which was published by Shields, where they have classified the regression patterns into 5 types. Type 0 is there's no visible remnant. Type 1 is completely calcified remnant. Type 2 is completely non-calcified, but fleshy remnant is there. Type 3 is partially calcified remnant. But then again, in both of these two, there's chance of recurrence. So one should keep type 2 and type 3 regression patterns on close follow-ups for a long term. And whenever there is a obvious evidence of recurrence and a fresh outpouching of the lesion or anything new is noted, then the lesion has to be treated then and there. Type 4 is atrophic choroidal flat scar. Coming to external beam radiotherapy, as we have already discussed, retinoblastoma being a radiosensitive tumor. Um, Usually, this was one of the earlier modes of treatment, and it's still used for extraocular retinoblastoma, where the stage is the tumor is not limited to the globe. It has already become extraocular. In such scenarios, external beam radiotherapy is revised always after enucleation. The idea is to give 30 to 40 gray fractionated over 20 doses. Disadvantage is that it affects growth of soft tissue, even the bone, and also causes orbital hypoplasia, and can also lead to secondary cancers in the field of radiations, and especially in cases of hereditary retinoblastoma, although the incidence is relatively rare. Coming to enucleation, whenever it's basically removal of the globe with the sclera, uh, and a part of the optic nerve. The ideal stump length is roughly 15 millimeters. Indication is that in case of non-salvageable eye or groupie eyes or even chemo-reduced extraocular retinoblastoma eyes or thysis bulb eyes. Let's move on to the other mode of chemotherapy, that is intraarterial chemotherapy. It was first performed by Rees in 1954, where he had injected triethylmelamine through the internal cavity artery. Uh, and it was not used for retinoblastoma initially. It was, but then again, it was because of its toxicity, it was abandoned and it was not popularized. Later on, in 2014, Yamane and Kaneko described the technique of selective ophthalmic artery infusion, which was later on popularized by Abrahamson Gobin, where direct intraarterial ophthalmic artery infusion was described in 2006. It is done in cases of unilateral retinoblastoma, mostly group C and group D eyes, where it is recurrent, and even after doing systemic chemotherapy and even plaque radiotherapy, the lesion is still persisting. In such scenarios, ISC can be tried. And other than that, in case of even subretinal seeds, not going even after treatment of intravenous chemotherapy, it's still persisting. Even in such cases, we can give intraarterial chemotherapy. There are different drug regimens which have been currently followed these days. The most common one is initially we start off with one drug regimen with melphalan. Then we move on to two drug regimen, that's melphalan with topotecan, and at times we move on to three drug regimen, that is melphalan, topotecan, and carboplatin. But then again, these drug regimens are still there is no definite protocol of how many times the drugs have to be repeated, and usually it's preferred that at least 3 times the drugs are given, and the response is to be noted, and as per the response, further planning is to be done. So here you can see a patient with the group C with subretinal seed. Now, post IC, it has completely regressed. Complications of this procedure is can be classified or divided into two groups. That is one which can happen at the time of performing the procedure. That is, when we are doing this intraarterial chemotherapy, we have to place a catheter through the carotid artery, and we in the process we can actually cause stimulation of the carotid sinus, which can eventually give rise to bradycardia and hypotension. Or even at the level of ophthalmic artery level, many a times it induces vasospasm, and at that point of time, the procedure uh, by which is usually performed by the interventional radiologist, they have to abandon the procedure many a times. Then coming to the local side effects, that is the choroidal occlusive vasculopathy and retinal artery emboli has already been documented multiple times in literature. Other than that, vitreous hemorrhage, branch retinal artery occlusion, cranial palsies, and extraocular muscle infarction has also been documented in literature. Unfortunately, we haven't seen any in our center. Then also certain extent of neutropenia still because of it's a chemotherapy. Post-procedure management involves that we must first of all do a thorough hemogram after every 7 days, and ophthalmic examination have to be performed, which include external examination, visual acuity testing, intraocular pressure measurement, and obviously a thorough fundus examination uh, uh, under anesthesia, and it has to be always documented. Let's move on to the newer advances in the retinoblastoma diagnosis and management. So, in the recent past, that is in 2000, that it is to 2018, Shields performed a study where Shields et al. Performed a study where they have actually been able to document the OCT findings of submillimetric retinoblastoma lesions, where they have noted roughly 20 submillimeter retinoblastomas from 16 eyes. Because they were using a handheld OCT machine in patients while they're performing uh, examination under anesthesia, and they describe two different signs. I'll show you the photographs. So here they have noted this is, as you can see, a hump is noted. Uh, uh, this is known as shark fin sign, which is noted at the level of outer nuclear layer, and this is a fish tail sign. This part, it's noted at the level of inner nuclear layer. So they have documented this, and possibly in future also we can slowly, as you can see here, the lesion is not that evident also, but because the patient I possibly had history of familial history of retinoblastoma, one should be okay. Here it is visible. So in such scenarios, we can start the treatment early. Then comes precision intravitreal chemotherapy. The idea is to induce or inject intravitreal chemotherapy for treatment of seeds, but then again to limit the damage of the surrounding retina, because the chemotherapeutic agents also cause problems in the normal retina as well. So how do we do it? First of all, uh, in such scenarios, we first localize the lesion under indirect ophthalmoscopy. Then usually these lesions are supposed to be located inferiorly. It's preferred that it's located inferiorly, and we inject the intravitreal chemotherapeutic agent and wait for the drug to settle down at the bottom where the seeds are located. We do not jiggle the eyeball so that the chemotherapeutic agent doesn't spread onto the macula and cause damage. So there are studies which have shown that this drug has functionally improved, and the mean number of injections required for reducing the vitreous seeds have come down from 4 to 5 injections to 2.6%, 2.6 injections on an average. Then there are drugs. There has been documentation of high dose intraarterial chemotherapy and intrathecal chemotherapy for the treatment of extraocular blastomas as well. And other than that, there have been recent also certain studies which have shown that retinomas, which were initially believed that they are kind of sequelae of retinoblastomas, uh, uh, they are still actually pre-malignant lesions, and they have to be carefully followed up in the future as well. This is one more new entity. that is new. It's not very new, but then again, it's currently gaining a lot of popularity. VCN1 is a genetically modified oncolytic adenovirus type 5. It basically designed to replicate the within the cancer cells in an altered RB EF2 pathway. Like I said before previously, how RB1 affects the cell cycle. So VCN disrupts the way an altered RB-ETF pathway, and thereby reduction the it reduces the disease to progress further. So there are studies which are curtailing to this, and eventually we are hoping that in the near future it will become FDA approved. Uh, Coming to hereditary retinoblastoma management, there has been studies where in utero also retinoblastoma can be detected with the help of fetal magnetic resonance imaging as well as ultrasound. Um, and there has been a recent study as well, not a study, it's a case report where uh, uh, yeah, Feroz et al. Had actually found they have diagnosed in utero at a 39 weeks gestation, a child was like the fetus was diagnosed of noted to have retinoblastoma in one of their eyes, and immediately after birth, they performed the specialist group performed selective ophthalmic artery chemotherapy in that patient. So this is kind of a brief overview of retinoblastoma. Um, Due to paucity of time, I did not include much of the other retinal tumors. If I go on talking about them, then it will, I think, stretch the time limit. I also have some videos for that. I think I can move on to that. Should I? I have some videos to show. That is how to
Yeah, please
place
go ahead.
brachytherapy. Am I audible?
Yeah. Dr. Deepshekhar, please go ahead.
Okay, just give me 1 second. Where did I? So this is a case of enucleation. It's a very basic surgery. Uh, the idea is to first of all create a 360-degree limbal peritomy for thysis bulbi patients with thysis bulbi. So and then we dissect the TNNs in all four quadrants, and slowly we hook the recti muscles and then pass vicral sutures and then disinsert them. And we usually prefer the myoconjunctival technique where we suture the muscles with the conjunctiva. And this is repeated on all sides. In all the four rectis. And along with that, we also remove the superior oblique and the inferior oblique muscles. And with the enucleation spoon, then we cut it. The idea is to also measure the optic nerve stump length and then place an implant. And after placing the implant, we have to close the wound in three different layers. That is posterior tenons first. Then here we are suturing the anterior tenons. And lastly, we suture the, just wait, I think I've skipped that part already. So yeah, lastly, we suture the conjunctiva. And then we place a conformer and we do a tarsorrhaphy. Yeah. So one more is a brachytherapy placement. Just let me show. So here basically we are placing a brachytherapy plaque for the tumor was located in the inferior part. So we have hooked the muscles. Now, as it's located in the inferior part, we are going to disinsert the inferior recti muscle. And then we have hooked the inferior oblique muscle. And now here you can see the plaque. This is dummy plaque. Dummy plaques usually have additional hole which help us to identify. So what we are doing is basically we are checking if the dummy plaque is in a proper location or not. So this is the dummy plaque which is placed, and this is the lesion which you can see. Now we first suture at the level of the eyes of the plaques, and then we take out the actual radioactive plaque and then place it. Anyways, plaza sutures. And then we, close the pectomy. And as per the medical physicist who's available, they tell us the time when it has to be removed. Yeah. Thank you. Uh, I will take questions if you have any.
I think wonderful presentation, Dr. Deep, and you have covered the entire details and all the intricate details that are important for the postgraduate, and wonderful videos. You hardly get to see, plaque brachytherapy. We read it in books and we talk about it, but then you've shown these beautiful videos. I'm sure the residents are going to benefit a lot from it. We have with us Dr. Ankita Aishwarya, who's going to initiate the discussion and follow up with the questions on this topic, which is very important for the postgraduates. Both as a long question, you get retinoblastomas in the long questions, and spot diagnosis of leukocoria, of pediatric leukocorias, you often do get. So, Dr. Ankita, you are free to ask questions to Dr. Deep.
Yeah. First, Dr. Deep, it was an awesome presentation. I think not just at the level of postgraduates, even the fellows, if they're watching, they'll be benefited from it. You have covered almost every part of it in a very beautiful and an extensive way. So, congratulations to you for this.
Thank you.
Keeping in point of view that it's based on like at a postgraduate level, there are few things which I would like to insist on. Number one, definitely the symptoms which you have mentioned. Leukocoria being the most common 40% which we see, but yeah, any children who are presenting with squint or decreased vision, red eye, proptosis, they should at least undergo examination under anesthesia. If not possible, then at least a retinal evaluation should be done for them, because many a times they are missed because of this, thinking that okay, it can be just a refractive error or something. Then, secondly, coming upon the differentials, yeah, that is again a very important part. Not just knowing that, okay, how are these, like thysical eye is there or epithelioma is there, PHPV is there. The important thing is how to differentiate from them. Like for the thysical eye, Dr. Deep, can you just elaborate like how, when a child who's coming with a thysical eye but is having a retinoblastoma too, can we, there are certain points which we can differentiate it, whether it's a thysical or a retinoblastoma? Based
Usually,
on
yeah, usually what happens is that first of all, whenever a child presents to you with thysical eyes, one has to take a history. Okay, so if it's because of retinoblastoma, there will be certain telltale signs. Like for example, the eye must have initially had a group E lesion that had eventually led to phthisis. So even if you're doing an ultrasound, which is must, you can actually pick up certain form of intravitreal lesions which are still there, which may be calcified. But then again, it's difficult to tell you whether it's active or not. And MRI helps in that scenario a lot, because what happens is that group E lesions, especially thysical eyes, if it was never treated, it's a treatment naive, there's likelihood that the optic nerve is involved at that scenario. So you can actually pick up conditions, pick up diseases with optic nerve involvement. The optic nerve will appear thickened, and that will be kind of an extraocular RB. Other than that, patients with phthisis in younger age group, most common reason is kind of trauma. So you have to first take a history of trauma as well. And you should always, when you are suspecting in lines of retinoblastoma, other eye also helps you a lot. If the child is younger, it is less than 1 year of age, it's unlikely that the child is going to have phthisis, first of all. If it's the child is having child is of around 2 years of age, possibly phthisis can happen. Then again, we have to check the eyes of the other eye as well as the eyes of parents, because it's a kind of hereditary disease which can happen. And MRI will also help you definitely. So mostly those that will itself do. Okay.
Very well mentioned. But one thing which is very important is in thysical eye, the calcification is mainly at the level of the cones, whereas in retinoblastoma, it's at the center.
Yeah.
So even on the base, if any child who is coming with thysical, even if we are doing the B scan, just looking at the calcification level, it's very important. We can differentiate it from both of them. The next thing which you told very important was the sibling screening, which is actually very important, sibling as well as the parent screening. And ideally what we follow is that sibling, at least within 2 weeks of birth, they should be screened. The first screening should be done. Also, with respect to the classification of retinoblastoma, recently this American Joint Committee of
Yeah,
they have
it has come
introduced
out.
PNMA. Yeah, yeah, yeah. in 2018. So that is also very important because they have included the heritable
Pathology
component.
as well as, yeah, genetic component they have
39 plus genetic.
classified.
Yeah. Yeah.
They have
So that
included
is something which is up leading. So even in your recent advances part, we could
it.
have included that also. That will help in the Viva and all those to add on the marks, I think. Thirdly, yeah, the other thing, any patient, like what are the indications when you ask the children with retinoblastoma to undergo bone marrow and CSF examination?
Usually what happens is that in whenever we see any patients or we on imaging, if we find any form of optic nerve extension or any form of extraocular, that is the stage when we're suspecting whenever the eye is already having extraocular extent. Only then we should be advising a bone marrow because we are suspecting Mets in such scenarios. But also in patients where after enucleation we have seen high risk features. I haven't discussed it here because of the paucity of time. So there are multiple things which I have skipped mostly. In such scenarios also, and we can do a CSF analysis, but usually we do it when we are suspect. We can see a palpable lymph node is available when on examination, and also extraocular extension has been already seen documented. Usually we advise in such scenarios.
Yeah, correctly. And also, the treatment of retinoblastoma has actually evolved, like from the
Yeah.
1970s when it was just an enucleation, then it followed to EBRT, then to the current therapy, IVC with focal therapy, and then moving on to the IAC. So I think even the postgraduates as at level, they need to know that how the treatment of the retinoblastoma has evolved over the years. Thirdly, regarding the plaque brachytherapy, just out of my self-interest, what do you use in AIMS, like ruthenium or iodine?
We use ruthenium. We have iodine, but we don't use it for this thing for intraocular tumors because it's available at we have a separate center for this thing, but we have both options, but we use ruthenium. Ruthenium is forgiven to us mostly.
Okay. And even for plaque brachytherapy, like for secondary tumors, they are like one of the very beautiful results that we have seen with Dr.
Yeah.
Mundaka. So that in that also, plaque brachytherapy is one of the very nice choice to go upon. Thirdly, regarding intraarterial chemotherapy, the dose and the regimen, yeah, definitely it's still a debate that like people use
Yeah.
one drug, two drug, three drug. But what we have seen yesterday also, we had a discussion on this. So we are using three drug, topotecan, melphalan, and carboplatin at
In
three
all
weekly.
cases.
Yeah, in
In
all
all.
cases. Yeah, in all
Okay.
cases. We are and at an interval of 4 weeks for 3 cycles. And
Okay.
the results for group B and C is fantastic. It's 100% eye and vision salvage. For group D, it's around 60% eye salvage along with the 100%, vision salvage with 80% and eye salvage is 100%. And in group E, it's 54%. So the results are really promising. We are yet to publish it. But yeah, it's a very upcoming and a promising results. I hope
We have a like we usually follow like 4 weeks regimen kind of thing.
yeah, 4 weeks.
But then again,
4
we also see because we have to keep in account with our this thing medical oncologist.
correct.
They usually because
Interventional
yeah
radiologist.
because we are also trying something like a VT regimen. Okay,
Hmm.
they have tried it. So in such scenarios, there is a discrepancy. Like if they have given already topotecan for systemic chemotherapy as well. So in such scenarios, already the person has already given topotecan and did not have much response. It doesn't make sense to give it again. So in such scenarios, maybe melphalan is initially given, but then again, it's a dicey situation. It keeps on evolving with time. So we still don't have a definite consensus on that. So we are still discussing.
Yeah, I agree, and it's yet to be published also. From postgraduate point of view, definitely for long answer, I think your presentation is more than sufficient. If they write, they'll give full marks. Everything you have covered. From the practical point of view, I'll just request you to give them few points which they should not miss whenever the case of retinoblastoma comes to them, because it's all also one of the tumors which we can save the life if they are treated on time. So, what all practical points you would like to give or to the postgraduate students at their level?
Practical points in the sense, whenever a child presents to you, always think the whatever worst can happen. For example, even a patient presents to you as with cataract, and you're not able to see uh, the fundus, or you're not able to diagnose what's behind the lens. You should be always erring on the side of ominous feature. For example, uh, a patient presents to you with red eye, and there is the pupil is 2 millimeters, you cannot see the fundus properly, you should always get an ultrasound done. It's always essential that you should be thinking in the lines of the worst case which can happen, and that will make you, pick up things which, you should not. This will help you not miss out on uh, scenarios like retinoblastoma. That is just one of them. But then again, there are many things that one should be doing, starting from the very initial stage to the later on stage. Follow-up is also essential, very important. Many times we have seen that the patient have to be counseled properly. Whenever you tell the parents that the patient will require treatment for a long period and has to follow up also, and not just that, whenever you break the news that the eye has to be removed, many a times the patients, the parents just leave, they don't even follow up. So you have to counsel the patient, and you have to, reassure them how, and you have to show the pictures of possibly the patients who are survivors, and to, ensure them that they are going to they will eventually lead a normal life as well. So it's kind of a scary situation for the parents who usually come to us, but then again, it's the job of ours to ensure that this happens in a, a proper way. So
Yeah, yeah, aptly said. Agree. Totally agree. And yeah, definitely patient counseling and initial screening is a mandatory thing and should be done at all the levels. At least even at the primary level, they can do the fundus examination if nothing else can be done.
yeah.
Yeah, a very beautiful presentation. Thank you, Pranita ma'am.
Thank you, Ankita, Dr. Ankita, for making the discussion so vibrant and adding all those important points and giving your valuable time. Thank you, Deep. Wonderful presentation as always. Thank you for sparing your time and giving this so much of uh, efforts to compile all the important information. So with that, we'll conclude the class and we come to an end of today's lecture on retinal tumors. Our next class is going to be on 24th October, that is Thursday, that Dr. Richa Wag is going to take on the topic of blepharitis and disorders of eyelash. This class was cancelled at the time when there were students who were on strike. So we'll conclude the last two classes in the coming Thursday and Monday. And with that, we'll come to an end of the oculoplasty series of the DOSPEP and move on to the next series that will be the retina series. So thank you, Dr. Deep, and thank you, Dr. Ankita, for being with us. Good night.
Thank you, Dr. Ankita. Thank you, Dr. Pranita, ma'am.
Thank
Bye, ma'am.
you.
Good night.
Night.